was like,
I think this is what happened last time.
There's usually extra questions after you hit that.
Yeah. Okay. Hello, everybody. Welcome to Rounds. How about I share a screen? There we go. Okay. Welcome to Rounds, March 20th. It's the first full day of spring, unless yesterday was the first full day. I'm not sure. Anyway, okay. The first case that I'm going to share is a dog. It is a 10-month-old Labrador Retriever mix. The history we got was history of third eyelid elevation and swelling, blepharospasm in the right eye, which is this one, off and on, for about a month. Unknown if trauma was involved. Right eye, collapsed anterior chamber, focal stromal ulcer, no signs of infection. Ocular ultrasound showed retinal detachment. And endophthalmitis, unsure if due to foreign body or trauma, rule out infection / neoplastic. The dog is otherwise normal. So here is the globe that we received. We always would typically do a dorsoventral cut, and when we display them to you, the cornea is always at the top, and the optic nerve and the fundus is at the bottom. So we have the cornea up here, which is quite opaque, and there's some brownish discoloration to it. The anterior chamber is not visible, so it looks like the anterior chamber is collapsed. What we do see is brown tissue lining the posterior aspect of the cornea, which is pretty consistent with broad anterior synechia and anterior chamber collapse. And then the lens is right here, and it's sort of oddly shaped with this protrusion anteriorly that sort of comes up and meets some brownish tan tissue, which is probably uveal tissue. And then the rest of the globe is actually pretty normal. So we did not see evidence of retinal detachment or very significant intraocular inflammation as far as we can tell grossly. So we got two levels of this eye. This is actually the deeper level. The optic nerve head is in the more superficial level. So here's the cornea, which is not completely sampled. There's a little artificial gap there. Right here in the center, we have some disorganized uveal tissue that sort of blends with the deep corneal stroma. There's some red areas of the corneal stroma, so that's hemorrhage, and that probably corresponds to the brownish area that we were seeing in the gross photo. And then you can see the lens kind of comes right up, and it's a little bit intimately associated with some uveal tissue here, which is the iris. There is no discernible anterior chamber, so the anterior chamber is collapsed. Here's our ciliary body here. Here's a ciliary body plica. Similar story on the other side. There's a little bit of anterior chamber visible right there where the arrow is pointing. Here's our ciliary body. We did a Swiss roll for this one where we actually cut the sclera to make it fit in a cassette. So we have some overlapping sclera and retina. I know it's not as pretty, but it saves us a couple dollars on these cases. And the storage of an extra large slide and block. So here's the retina here. As I said, grossly, there was no evidence of retinal detachment, at least noted grossly. And I think this is artifactual separation. And we didn't sample the optic nerve head in this section. Remember, I said there was sampled in a more superficial section. So let's go ahead and jump right in and see what we see here. So in this image here, you can see Descemet's membrane coming along here, and then all of a sudden it disappears in this area where the corneal stroma becomes quite busy. It is diffusely vascularized. So it is a fibrotic corneal stroma. And then also the anterior iris surface kind of blends with that deep corneal stroma. So we have areas of true anterior synechia up against the back of the cornea. The corneal epithelium is also a bit hyperplastic and keratinized. And then there is our corneal stroma, which is very busy. So it's populated by fibroblasts or reactive keratocytes, and it's fibrotic. And then here is iridoid tissue that kind of blends with it in the area where Descemet's membrane is discontinuous. We have a little bit of iridoid stromal inflammation there. And then we didn't sample the perfect connection between the iris and the lens, but here is a pretty convincing section that's probably adjacent to what we saw grossly. So the anterior lens capsule is here. And it, like Descemet's membrane, is suddenly or abruptly discontinuous. And what we have here is degeneration and liquefaction of the anterior cortical lens fibers, and then we have some inflammatory cells mingling with them. So this right here is consistent with a penetrating trauma, along with Descemet's membrane rupture, focal anterior synechia with the iris there, and then this anterior lens capsule discontinuity. When we follow it around, you can pick up a little bit of inflammatory cells here and there. There's a little bit more in the posterior chamber here, and we can take a peek at those real quick. So we have some lymphocytes and plasma cells in the iris stroma, and then in the posterior chamber here, we have some neutrophils and then some macrophages, some of which contain some melanin. So when I saw this, I immediately jumped to HiMag and started looking in the lens for bacteria, because I thought this is totally consistent with what we call septic implantation syndrome, which is an implantation of bacteria into the lens, proliferation of the bacteria, and eventual suppurative phakitis, and usually then the eye sort of explodes with intraocular inflammation and endophthalmitis. However, in this one, as I scoured this lens, I found no bacteria. But when I went to a different spot, I found something else that made me go, oh, let me see if I can find it again. Whoop, sorry. I found this guy. And I thought, oh. So let's look a little higher. Let's get him in the center there-ish. So this is a fungal hyphae. And I said, oh, it's that kind of septic implantation syndrome. So then I went back to the anterior lens capsule. And here it is. It's sort of it's kind of moth-eaten and being dissected by inflammatory cells. And as we travel a little bit more axially, you start to pick up more of those organisms that are dotting this lens capsule. So this is the fungal variety of septic implantation syndrome, which is much more rare than the bacterial variety. That is the most important findings of this case. The retina is artifactually detached, so I'm not sure what they were seeing on ultrasound, but it may have been this inflammation that's in the vitreous. It's a little bit hard to say what they were seeing on the ultrasound to let them think that it was retinal detachment. Let's see here. Not uncommonly with a lens-induced uveitis or process, there's often some lymphocytes and plasma cells in the retina, mostly around blood vessels. So this is a common finding in many or all species when you have a lens-induced inflammatory problem. And I think there was evidence of glaucoma, but now I can't remember if I confirmed it histologically or not. Not surprising that this globe would have been glaucomatous. And actually, another finding at low mag, the limbal sclera is quite thin, which is consistent with buthalamus. So there was some buthalamus here as well. So those are the most important findings. So this is, as I said, the fungal variety of septic implantation syndrome. So we'll go back here and read that. So lens capsule rupture with suppurative phakitis, intralenticular fungal hyphae, and cataract consistent with septic implantation syndrome. So we typically blame the cats and their very sharp claws for septic implantation syndrome. I don't think anything differently in this case. So I think for whatever reason in this case, the cat claw had a fungus attached to it and not bacteria, or perhaps it had both and the fungus grew faster or something. I'm not really sure.
Onychomycosis.
Yeah, onychomycosis, yeah. Fungal infection of the toenail. But anyway, yeah, gross. Anyway, so this is a nifty example of contaminated penetrating trauma that also caused lens capsule rupture. Doesn't look like there's anything in the chat. Any other thing to add? Questions?
Just made me think about if we can still call it septic when it's a fungus.
Good point.
Mycotic implantation syndrome.
Yeah. Leandro says maybe we shouldn't call it septic if we're referring to fungus. but that is a very good point.
Yeah, but it's a useful name for the syndrome itself. So.
Yeah, and for us to be able to find them again in the database.
Absolutely.
Which is often the reason why we call things the way we do, so that we can find them again.
Yeah.
Okay, cool. Anyway, so that's a good one. So this case had a 1 month history of eye disease. We have some cases where it's months to years between suspected or known trauma and then sort of explosion of intraocular inflammation, which is really interesting. So 1 month is relatively short. And this was a young patient, so probably a little bit too curious for its own good and too curious about that sharp feline. Okay, cool. Moving on. Next case is the globe from a 6-year-old Shih Tzu Poodle mix. The history we got was fairly brief, and they say thesical eye, blind, ruptured, although they didn't say anything about where, collapsed anterior chamber, and no glaucoma. So here is the eye. It's kind of a hot mess. Cornea is at the top as usual. So the cornea was intact as far as we can tell grossly. It was kind of bulging forward, and overall the globe seemed a little bit small and a little bit distorted, which is consistent with thesis bulbi. The lens is actually really hard to make out. We did note that there was this fluid-filled pocket attached to the posterior sclera, which is really interesting. We said on transection, it appeared to be a cyst. So that was about it, other than obviously there's a lot of hemorrhage in this eye, and really discerning the uvea was pretty difficult. Figuring out where the retina was very difficult, and same with the optic nerve head. So this is a great example of some stuff. So let's go ahead and jump right in. Oops. All right. So focus there. Okay. So here is the, wow, it's so dusty. Sorry. Try again. There, that's better. Okay. So there's the cornea at the left there. In the middle, it's hard to make out much of what's going on. There's some brown tissue, which is probably uvea. Obviously, there's a lot of hemorrhage and some pink stuff. In the center of the globe, there's some more pink stuff admixed with some more hemorrhage. There's some brown, purplish stuff, I mean. And then when we move out to that fluid-filled pocket, at this low mag, you can pick up, there's a segment of some hyaline eosinophilic stuff, which is actually the lens capsule. So this is, so in this plane of section, both the cornea and the sclera are continuous. I believe this is actually where the optic nerve would have been entering the eye, but we didn't quite sample it. No doubt it was difficult to identify histologically, or I mean, grossly for the folks who are cutting this block. So they get it, they are excused from not sampling it on this one. But anyway, so we did not sample an area of scleral or corneal discontinuity. But let's go ahead and go higher mag and see what we have there. So most of the cornea is fairly normal. There's a little bit of neutrophilic inflammation there. But we're going to go ahead and go higher mag here so that we can take a peek at Descemet's membrane. And so as we follow it along more peripherally, it is suddenly discontinuous with a nice blunt end, which is consistent with a break. And whenever we see peripheral breaks in Descemet's membrane, we first think about blunt trauma. So Hobbs striae typically develop axially, at least in our experience, whereas blunt traumatic breaks in Descemet's membrane occur peripherally. And then we have what should be the area where the iris is connecting to the sclera, and we no longer have that connection. So it has been torn away from the sclera, and in its place, we have a lot of hemorrhage and some plump spindle cells, which are some fibroblasts. We do start to pick up a little bit of a hint of previous uveal tissue with all the pigmented cells scattered around. Here is some more convincing uveal tissue. I'm not sure if this is iris or ciliary body. If we go a little bit further here, this is actually what I'm assuming is more fragments of Descemet's membrane. So we have cyclodialysis, which is tearing away of the iris and the ciliary body from the limbal to equatorial sclera. And on this side, at least, we have some supraciliary and then some suprachoroidal hemorrhage as we follow that back. The other side is a similar story. We have a nice break in Descemet's membrane there, nice and blunt. Where the iris should be, it is not. And when we travel back, we do find some uveal tissue. The identity is difficult to make out, but once again, here is a squiggly eosinophilic basement membrane, which I really think is Descemet's membrane. Another possibility would have been part of the posterior lens capsule, but I'm pretty sure this is Descemet's membrane. And then, as I said, when we looked at it on the subgross, all this pink stuff is some pink stuff. It's a mix of fibrin with some inflammatory cells, some red blood cells. And then actually, I'm pretty sure this is fragmented and necrotic retina. So we got diffuse retinal detachment, and some of it is up here in sort of the anterior segment. When you looked at really the gross picture and then the subgross, you thought like, oh, well, there's the lens right there. But actually, this is just more of the same pink stuff. So I think this is probably a lot of fibrin, a few inflammatory cells, and maybe some degenerating red blood cells, although we have some intact red blood cells present as well. And then let's see here. So let's go on out to that sort of cystic pocket in the episclera or orbital tissue. So there is a beautiful example of lens capsule rupture and curling, and I brought my sound device to auditorily give an example of what this is. So there you go. That is what the sound of lens capsule makes when it breaks and then curls up like that. I hope you could hear that over the microphone to the virtual audience. Anyway, so we have lens capsule here, which is all wrinkled. It was discontinuous up there, in the center of that coil. So there's the end right there. It's probably multifocally ruptured in this case. So this was the interior of the lens. You can see there's some remaining lens epithelium there, and where I was originally down there. This is some degenerate, probably lens fibers. And some lens epithelium. So we do have a little bit of a fibrous reaction on the inside of the lens capsule here with some melanin pigment, and then also in the episclera around it. There's another discontinuous part of the posterior lens capsule. And I know it's posterior because of how thin it is. Oops. And then one more little bit here. This, I'm pretty sure, is a little bit more of the retina. In this case, it's actually not necrotic, but it doesn't look like retina anymore, so it's quite degenerate. I could be wrong about the fact that is retina, but I'm pretty sure that's what it is. And then as we carry on back into that orbital tissue, all of this is fibroplasia. So we have a lot of plump spindle cells, which are probably fibroblasts, and some melanin-laden cells, some of which are probably uveal melanocytes, and some of which are probably melanin-laden macrophages. So, and then that is about it. More of the same inside the eye, posterior segment. As I said, we didn't sample the optic nerve head, and I think it probably was really hard to identify. So this is a fabulous example of blunt trauma leading to cyclodialysis or peripheral breaks in Descemet's membrane, cyclodialysis, chronic intraocular hemorrhage. They did not give us a duration in this case, so I have no idea how long ago it happened. But with that amount of fibroplasia, I would say probably days to weeks. Is what I would probably guess. So presumed posterior scleral rupture, which is unsampled histologically, with lens extrusion into the orbit and lens capsule rupture with advanced cataract. Peripheral breaks in Descemet's membrane, a marked chronic intraocular hemorrhage, cyclodialysis, an extensive, I didn't point that out, but uveal, and then also retinal necrosis, which I did point out. So that is just kind of a great example of blunt trauma in a dog eye. And with that, I will pass it off to the next person.
So this is an 18-year-old spayed female domestic short-haired cat. There is a description of significant 4+ corneal edema with a white appearance to the right globe. There's neovascularization of the cornea. There's some ulceration and facet. So a really abnormal cornea. Conjunctiva was thickened and irregular. The globe appeared asymmetric and larger dorsolaterally. And that's all I'm going to share from the history. So we have our gross view, and it really shows off this corneal change. So the cornea is roughly from here to here, and it is extremely thickened. This isn't just a function of the cut. It's just a very, very thickened cornea. It's also completely opaque and white. And then you can also see that this tissue sort of blends immediately into the anterior uvea. And there kind of is a lack of distinction between the iris and the cornea, implying maybe some degree of synechiation. So lots of interesting things in the anterior segment of this cat globe. And yeah, okay. Let's see if a subgross looks okay first. So here's that cornea again, and there's a lot of pink on the H&E, and it's still really, really thickened. You can actually see this really lovely sort of wrinkled or ruffled decibase. And then you can see that similar tissue, pinkish tissue, extending from the cornea onto the anterior uvea. But subgross doesn't look as nice, so we're going to switch right on in. Okay, so now the cornea is facing to the right. There's some stuff on the slide also. One moment, please. There we go. So again, this really thickened cornea, and oftentimes when there's too many cells, it would look more purple from subgross, but in this case, it's very pink, and we'll see why in a second. But there is something added here. Basically, there's too much collagen. And again, we can see this tissue extending onto the anterior iris, and the broad anterior synechia is even more apparent in the other iris leaflet. And in this side, this pinkish stuff is in the iris stroma itself and also carpeting uveal surfaces. And finally, way at the edge into the ciliary body here, and sort of dissecting a little bit the supraciliary area, we have a little bit more purple, so that these cells are a little bit more viable over here. And if we drop down on these cells in the midst of the cornea, that is indeed why we have mostly just pink expansion in this area. Basically, there's too much collagen and also sort of gaps or ghostly outlines where there maybe were cells previously, but they've become necrotic. So basically, these were too many cells, but now it's very necrotic in these areas. So So let's head to an area where these cells are more viable to get a better sense of things. So over here, you can see that we have spindle cells alternating with these collagen fibers. And then in this area where it's really viable, we see some really interesting features. So we still have spindle cells, but then there's also these frequent multinucleate cells in between those. This one's in particular quite good. You can see the outline of that multinucleate cell pretty well. Whoops. I should not bump it with my finger and go higher. All right. That would be useful. So here we go. Again, streams of spindle cells interdigitating with these collagen fibers and frequent multinucleate giant cells. Here's another look at those spindle cells interdigitating with collagen out here. So this is a neoplastic population, which is mostly centered on the cornea and then also extends into the anterior segment. There is actually a bit more of a viable area in the cornea in this little extra slice we have on the side here. Spindly cells again. And then you can see it in particular on this little extra slice invading the uveal stroma and also carpeting the surface of the uveal stroma as streams of spindle cells. So we have a sarcoma. is what we called this one. And presumably it arose in the cornea because the bulk of the tumor is there, although it's difficult to tell exactly what structure it arose from at this point. And extended into the globe from there. And the multinucleate cells are an interesting feature, at least in terms of soft tissue sarcoma. There's a condition which is currently known as undifferentiated sarcoma, previously known as like malignant fibrous histiocytoma or something unusual like that, but undifferentiated sarcoma currently. But regardless of what you kind of want to call it specifically, it's a sarcoma, a malignant mesenchymal tumor. And it's difficult to tell the specific tissue of origin at this point. So just a really unusual tumor. We don't really see this too frequently. In cats, we do see spindle cell tumors fairly frequently in the eyelids, and often they are nerve sheath tumors. But seeing it mostly in the cornea and then ascending into the globe like this is unusual.
I also first thought, another thought was this could be a post-traumatic sarcoma, but the lens is
That is a
obviously-
thought.
There's a cataract, but it's not anywhere close to causing a sarcoma.
Good point. If you see an invasive spindle cell tumor, it is definitely a good idea to have post-traumatic sarcoma spindle cell variant on your list. But yeah, it's not really centered around the lens, and the lens capsule isn't obviously ruptured. So yes, very good point.
In general terms, I guess a pathologist might argue that can never rule out a melanoma, but
Also a good
this
point.
one really does not look like any type of melanoma we see. And so I think it's very unlikely.
Or maybe something to kind of put in the back of your head. Yeah. Never stake your career on this couldn't possibly be a melanoma, basically.
Famous last
Yeah,
words.
famous last words. I didn't need to do that. Wait, I can put it back, maybe. Nope, I can't. Okay, I'll fix it later. Nope, okay, here we go. Everything's fine. I'm technologically competent and everything. Here's the diagnosis for you. And that's what we called it. So I gave it a DDX, undifferentiated pleomorphic sarcoma, because those multinucleate cells, but trying to put a specific name to it probably doesn't really matter in this case. So yeah. All right. If there aren't any other comments or questions, we'll do the next one.
Ryan Taylor piped up and said, based on the gross image, I thought it could have been a stromal invasive squamous cell carcinoma. So yeah.
Good thing,
That's a good
yeah,
point.
for gross differentials, cats get a fair amount of like highly invasive carcinomas of the ocular surface. Grossly, I also had on my differential list lymphoma. We have like some degree of sort of anterior segment lymphomas, maybe, but also still kind of a weird distribution. Probably a sarcoma would have been a better gross differential. Carcinoma would have been a better gross differential.
Yeah, just one point, the tumor we call stromal invasive squamous cell carcinoma, we mostly see in horses. I don't remember if we've seen that variant like the horse in other species, but yeah, I think a invasive squamous cell carcinoma in this case would be definitely one of the phrases. If I got that gross in a cat with no other explanation.
I know I've seen that pattern in the corneal stroma of dogs and cats, but I think there's often more of like an ocular surface, more exophytically oriented part of it, unlike in horses, where it can literally just be in the stroma. So
yeah, sometimes it's a clinical differential for mycotic keratitis in horses, but it doesn't respond to antifungal treatment.
Yeah. Ryan said, I thought we had some in cats. And yeah, I think that's what I seem to remember too, Ryan. Yeah.
Cool. All right. This case may be somewhat more mundane, but still cool. I won't give this patient's name, but the patient's name starts with Mr. and it's a cat. And there's been a theory tossed around in Coplow that more cats have names that start with Mr. than dogs. And it bears out in the database, which is interesting. Anyway, that's just a fun little aside, which is not really important. But anyway.
It is.
The things we do to entertain ourselves
Right.
when we have a brief moment for some mirth.
Indeed.
We always look for
One must-
patterns, and sometimes
That's
we find
right.
patterns on things there are. Relatively irrelevant.
It is a demonstrable pattern, though. It's
It
there.
starts with a mister on a Wednesday afternoon
More likely to be a cat.
on a summer month, like a cat.
Yeah. It could be like a party trick. Like you could be all like, aha, I know the signalement of this patient. Anyway, so this is an 18-year-old neutered male domestic short-haired cat. So they say ophthalmic exam revealed good comfort, but an absent menace response, and an absent dazzle. There is a clear cornea, but dark hyphema fills the anterior chamber, and they couldn't see the pupil. And they have a history of elevated intraocular pressure in the 80s with no topical medication. And it measured 52, presumably closer to enucleation and on meds. So pretty bad glaucoma. The other eye, they describe iris atrophy and nuclear sclerosis, but nothing kind of more than that. And then there's some other stuff in the general or systemic conditions, which I will withhold for now. But we'll read that in a moment. So here is the gross exam. And interestingly enough, part of the reason I actually grossed this one, and part of the reason why I took this gross photo was because there's this interesting sort of red tincture to the cornea throughout. But I don't think that really translated to anything histologically. It's just interesting grossly. Like sort of the blood kind of like imbibed into the cornea or something. But I was thinking it might be stromal hemorrhage. Regardless, the interesting thing, though, is that the anterior chamber in this case is indeed full of hemorrhage and probably fibrin. And that's kind of the main thing to see grossly. Okay, now we can fix this. There we go. It's fixed. All right. Whew. All right. We're not going to do the subgross. We're just going to do this lowest magnification. So we're tracking on the cornea here, and as we do, we again see histologically as well that significant fibrin and hemorrhage in the anterior chamber. And yeah, again, histologically, that interesting kind of reddish color of the cornea didn't really translate to much, which is interesting. Maybe just sort of a function of the blood in the anterior chamber. Kind of out of focus a little. So the blood kind of blends into the iris leaflet, especially on this side, and we'll look at that a little bit closer in a hot second. We also have a little extra slice off to the side here. Again, lots and lots of hemorrhage, mostly in the anterior chamber. And we're going to look closer at this large vessel in the iris in a second as well. There's a little bit less hemorrhage in the other chambers of the eye, mostly sort of posterior chamber. But the anterior segment stuff is what we're mostly going to look at initially. So let's go back to this iris leaflet here and take a look at where the blood kind of blends in. And so basically we can barely make out kind of where the iris stroma ends and the hemorrhage, which is starting to sort of organize, begins. So like maybe roughly here. And then we have all this fibrin with spindle cells percolating out from the iris and kind of partially organizing that along with that hemorrhage. As we track a little bit further along in this iris, I'm going to pick an area and stick with it. I think I'm going to pick this area and stick with it. So even though we can still make out the outlines of the melanocytes at this level in the iris stroma, they're pretty much just outlines. There's not a lot of nuclear detail. There aren't really a lot of like stromal resident cells evident here. There's kind of karyoretic debris peppered throughout and maybe even some free melanin. So this iris is necrotic. Basically, we have a segmental coagulative necrosis here. And I would suspect in this case that this is basically ischemic, but we'll take a look at that vessel here to kind of decide about maybe why. So let's walk back over to this slice over here. This is just the best vessel. Not a whole lot of vessels were interesting, so we're just going to focus on this one. So in the iris stroma, we have this small caliber artery. We have the endothelium here. And then kind of between the elastic lamina, which is pretty evident like here, and the endothelium, there's kind of like too much collagen here, basically. So called this a subintimal fibrosis. And so some degree of vascular change here, which in a cat with hemorrhage into the anterior chamber and ischemic sort of segmental iris necrosis and vascular changes like this in the iris I would have systemic hypertension as my top differential. So an ocular manifestation of systemic disease. So for whatever reason, in cats, the manifestations of systemic hypertension may more frequently present in the anterior segment than in dogs, for example. In a dog, you most often will look for hypertensive changes in the blood vessels, more so in the central choroid, around the optic nerve, and or in the retina. And you can still see the changes there in cats too. It's just more frequently in cats, or at least more frequently in cats than dogs, you'll get some iris changes and anterior chamber hemorrhages as a consequence of hypertension. However, there can still be posterior segment manifestations, and in this cat, we're going to go back to that optic nerve, I promise. We have areas here in the retina. So the RPE here isn't really affected. There isn't really tombstoning or anything like that. However, the outer photoreceptor segments are basically gone here, and you have occasional macrophages kind of nibbling at them. Go even closer. So you also have thinning of the outer nuclear layer. There's also glaucoma, which explains why, in addition, there's no ganglion cells in this segment and no inner nuclear layer really either. So the retina is kind of under attack from both sides to some extent. But so we have some macrophages in the subretinal space, and oftentimes those macrophages are lightly brown, so maybe a little bit of hemosiderin. And I would be suspicious of multifocal retinal detachment, maybe kind of more historical, especially with how the RPE isn't really unhappy, at least at this stage, and could be a consequence of very minimal sort of chronic subretinal hemorrhages, which would also fit a suspicion of systemic hypertension in this kitty. And then in addition to seeing the more inner atrophy in that segment, when we dropped in back the optic nerve head to show off, actually, I kind of like that magnification better, to show off that cupping and atrophy. Whoops, just leave it like that. So definitely glaucoma in this case, as they reported clinically as well with that elevated IOP. And in this case, presumably just the organizing hemorrhage filling the anterior chamber would not have let aqueous pass. You shall not pass. You know, there's reason enough for glaucoma as well. A case, excuse me, of presumed systemic hypertension in a kitty, showing some fairly classic presentations histologically. And the systemic health information that I withheld originally features renal disease as a biggie, which is particularly interesting. Also a history of I-131 treatment, so presumably some degree of hyperthyroidism in this cat's history also could be a risk factor for developing systemic hypertension. And the cat also has heart disease and arrhythmia, so there's some reason for cardiovascular disturbances basically in this patient. And that's it. I don't need to push the escape key. I really don't. All right. There we go. Here's some diagnoses. I left the main diagnoses that kind of pertained to the hypertension or sort of ocular manifestation of systemic disease. So I left out a few, but there's still a lot of words on this page. So that's it. And if there aren't any questions, I will move.
All right. So I'm sorry to be an outlier, but my patient is also a Mr.
Oh,
then it's a dog. I'm sorry.
And everything.
But this is a
Statistical outlier.
Yeah. Well, it's a 9-year, 8-month-old Chihuahua Pomeranian mix.
That's basically a cat.
It's basically a cat. Like, so, you know. All right. So right eye from a 9-year-old Chihuahua Pomeranian mix came with a history of negative manus and dazzle and severe diffuse corneal edema and significant vascularization from the limbus that they said extended actually for 5 to 7 millimeters all the way around the globe. They weren't really able to see much inside the eye, but they did suspect that there was hyphema in the anterior chamber. We did not have a gross photo for this one, but I picked sort of a representative one for this case. So we could see some red liquid in the anterior chamber, so consistent with hyphema. There's a little bit of blood in the vitreous, which ours was brown and liquid, so it kind of corresponds with that. This one you can maybe see a little bit of some fluffy material in the vitreous as well. We didn't quite see that in the current case, but it's probably something that you can see in cases such as these. All right. So all right. So I'm going to make my way to the front of the eye here. So here we have cornea. It's a little bit hypercellular here. We got some neutrophils and blood vessels coming in. We can see our hemorrhage in the anterior chamber, so consistent with hyphema. Along the anterior surface of the iris, there is a fibrovascular membrane here. So, and then it's tugging on the tip of the iris leaflet and pulling it outwards, so some ectropia on uvea. If you follow it down towards the angle here, it crosses the angle and causes peripheral anterior synechia as well. And then we've got some nice cataractous changes in our lens with some liquefaction. And let's see, we've got some posterior migration of the lens epithelium. That really should only be on the anterior portion of the lens capsule. You can see it migrating backwards on the posterior, some liquefaction, and some more Gagnian globule formation here. So pretty mature cataract. But what we also see here in the anterior vitreous is this little like cluster of sort of bland cells. Not much going on with them, pretty kind of monomorphic, bland, no real mitotic figures or anything. And as we keep looking around, we can see that there's kind of little rafts of them. They're a little bit necrotic here, where they're a little bit more pinker and loss of cellular detail. But these kind of aggregates here in this location, and they're kind of bland, sort of spindle cell looking features. And the other thing to note is that there's like no vasculature associated with it. So they're not really consistent with like fibroblasts trying to lay down like a fibrovascular membrane or anything. So these are consistent with like a proliferation of glial cells, which we see in a condition of canine ocular gliovascular syndrome, or COGS. And with these cases, they are often associated with hemorrhage in the vitreous that usually comes from, I'm trying to find my optic nerve head here, like a proliferation of small blood vessels that come off the optic nerve head. We didn't really have that in this case. I think we don't often see that little proliferation of blood vessels, but it is definitely a feature of COGS.
It's the vascular portion of the name.
Yes. Thank you.
Sometimes also they might come off of the central retina, not just the optic nerve.
Okay.
And very often, if you keep going deeper, you might be able to find them. It's just that cells are so classic that sometimes they got better things to do. You know?
Yeah. Yeah. There's a little bit of lymphoplasmacytic retinitis, some ganglion cell loss, and we kind of had a tangential section here of the optic nerve head, but we did say it was cupped grossly, and it was a little bit gliotic here in the optic nerve, so consistent with glaucoma. And so this was just a really interesting representation of COGS and the COGS in dogs. So we don't really, let's see, don't really know where the cells are kind of coming from in this glial proliferation, but they usually aren't really recognized until the dogs develop a secondary fibrovascular membrane, like glaucoma. which we see in this case. It's usually, I think, a vast majority in our collection are unilateral disease, and it's not really associated with systemic disease either. It seems like half of our cases are Labrador retrievers are what's represented, but the other half is like a wide mix of random other breeds. Yeah.
Yeah, one of the questions I have with COGS is, well, there are many, but one interesting idea is the vascular component of it. If it's a primary part of the disease, as you know, comes with we have this proliferation of glial cells plus vessels, or if the vascular component is just a consequence of the dying off of those cells and release of VEGF, like a fibrovascular reaction. Because one of the things that I think I've seen or we started paying attention is how thick those bifidums, those fibrovascular membranes are in these cases of COGS. They tend to be very robust and very vascular, which makes me think that there is a strong VEGF-driven sort of response. So, in one hand, it could be that all the vasculature from optic nerve retina to the bifidums is just a reaction of the dying glial cells or the actual glial cells, or it could be that the optic nerve retinal proliferation is part of this faulty migration of embryonic tissue, like we see with a PHPV, and that's so we don't actually know that.
I think they did VEGF staining on the cells in the original paper, right?
Mm-hmm.
And
yeah, they do.
Yeah, they do express VEGF.
Yeah, they do express VEGF.
Okay,
which makes sense.
Yeah.
And so to kind of piggyback off of this COGS case, this next one's sort of in the similar vein here. It's a 6-year-old female-spayed French bulldog. This is the left eye that presented in December of 2021 for evaluation of a cloudy left eye, and they diagnosed glaucoma and had been medically managed pretty well until it wasn't, and it was now painful and vision loss, and so they took out the globe. In this one, sort of similar to the previous case, we kind of got this kind of condensed material sort of in the anterior chamber here, and our lens is kind of very wrinkly and shrunken. Probably a hypermature cataract. Correctly. All right. So since I'm just sort of springboarding off of this one, there was a little bit of a fibrovascular membrane in this one as well, along the anterior iris. Hypermature cataract, we've got lens capsule wrinkling and quite a big, large amount of liquefaction of the lens fibers. The lens capsule is sort of discontinuous, but there's no inflammatory reaction to it, so it was probably an artifactual rupture. But what we do have is, again, in this anterior vitreous is kind of clumped vitreous that are lined by spindle cells. Again, very bland, no blood vessels associated with them. A little bit of hemorrhage maybe around in the vitreous as well. But I guess we've seen this kind of presentation of COGS, a little bit atypical presentation here of this like bland proliferation of the glial cells that kind of line the condensed vitreous. We did offer GFAP immunohistochemistry just to sort of confirm that. And so I have that here somewhere. And so these bland spindle cells are all positive for GFAP, which is gliofibrillar acid protein, which stains glial cells. So confirms the glial origin of these bland cells around the vitreous.
Were there any vessels of the HED?
Like in the optic nerve head.
Yeah, like the
Uh,
vascular portion, right?
Again, no. I think I've had 2 cases, and my 2 cases haven't shown me the blood vessels. I want to see them.
I think
I'm sure we have them.
we could interpret that 2 ways. Either that we just haven't sampled them in a lot of
Mhm.
cases, or that it is a secondary effect of the cells, and some of the cases we see just haven't developed them yet. Who knows?
Yeah, I definitely do that.
But then again, we often see a lot of hemorrhage.
Right.
And it's not often hemorrhage in the anterior chamber, so presumably it's coming from vessels somewhere in the posterior segment.
Yeah, there's a cute little mouth-looking hemorrhage in that gross image there.
Yeah.
So if you go back, there's that linear thing there in the back. And just one thing for the pathologist listening there, if you end up with a case of COGS and you do GFAP, it can be variable. Like the positivity for GFAP can be regional, meaning sometimes you put it on one slide and a few cells will be positive and some will not. And sometimes it's not really convincingly positive. So I wouldn't rule it out. If you got a classic case of COGS that really looks like COGS, if you end up with a GFAP that looks a little bit iffy, I wouldn't rule it out just because of that.
In cases where clinicians actually see the eye before it's full of blood, sometimes they'll report that there's white material in the anterior vitreous. I can't remember if it was a clinician or Dr. D who called it popcorn-like.
Yeah.
I don't remember. But anyway, yeah. And I think our general theory is that it's probably some sort of rest, like an embryonal rest of cells, yeah, like remnant that has probably been there since the pup was born or during eye development. Somehow those cells kind of end up in that vitreal space and then continue to proliferate. And because they don't seem to instigate blood vessel growth actually to them, which is kind of interesting, they undergo necrosis, presumably ischemic necrosis, and hence the VEGF as they cry out for blood and oxygen. But yeah.
Very poetic.
Is it usually unilateral?
I think the majority of the cases we have are, but
And there's no systemic
Mhm.
disease that we've ever found. So it's not associated with any extraocular problems.
Also, interestingly, once we started looking into the possibility of it being a remnant of an embryonic structure, I've looked back and I don't think we ever found any another associated ocular abnormality, like in terms of like congenital abnormality in these cases. My idea by looking into it was, if we start finding like anterior segment dysgenesis with these cases or other congenital abnormalities, that the likelihood of this also be something congenital would increase. But I don't know if that assumption is even correct. But regardless, there were no associated other congenital abnormalities.
all right.
And that probably summarizes everything we know about COGS.
Yes, exactly.
Yeah, that's good.
Cool.
Yeah.
Excellent. All right. I really like the photo on this one.
That is beautiful.
So
Wow.
this is the left eye from an 18-year-old spayed female Himalayan cat. So what we have grossly is this big black void here. And then this little sort of white area on this side. And then on cut section, we can see that the black area is this really thick kind of black area in the cornea, which is consistent with their clinical findings where, I will point out one more thing before I give them the clinical findings. We can also see here is iris leaflet here is cornea here, and the iris is coming out where the cornea should be connected here. So we have a corneal perforation with some iris prolapse here, which was basically their whole diagnosis was corneal rupture and then they suspected a corneal sequestrum, which would go along with this black or even maybe dark brown.
That's the darkest question ever.
Yeah, I know.
Like a chunk of charcoal.
Chunk of charcoal, yes. Yeah.
Ryan like suspects a question.
Maybe because it was so black.
Right.
Yeah.
Yeah. That's,
Body, small one.
All right.
Maybe they're humble.
right.
Didn't want to be too presumptuous.
Yeah.
Okay, so limbus here, cornea here, little bit of cellularity here, which is blood vessels and such coming in. We have our corneal stromal loss here, and then it's a little bit folded. You can imagine it's probably hard to section through this because it's probably a little bit thicker and maybe drier because this is the sequestrum here. That's all brown. We see a little bit of cellularity on this side. We have this little pink line coming out here that we'll look at closely. And then here's our gap here in our peripheral cornea and prolapse of iris, and then lots of just inflammation associated with that.
Some shmoo.
Some shmoo. All right. All right. All right, here we go. All right, so I'm going to start sort of on that side. Again, our cellularity here, blood vessels and fibroblasts and other things coming in to try to help with this corneal disease. I want to point out like the cellularity of the corneal stroma here, and even deep, we can see like a nice number of keratinocytes scattered here. As we head towards that sequestrum, we can see some like vaculation in the corneal stroma, and we see these little downgrowths of epithelium here into the stroma, which is consistent with collagenylysis. So the epithelial cells have sort of lost their connection and are falling, melting into the corneal stroma. And then as we keep heading towards the brown area here, it's very hypercellular here because all the neutrophils are coming in. And then again, I sort of apologize for the fold here, but as we kind of go through, you can see that there's not very much cellularity here. And so the sequestrum sort of is like necrotic and doesn't really allow the cells to sort of penetrate. And so here's a nice example on the other side where you have all of these neutrophils that they want to get in. And so they kind of have to go single file into the sequestrum.
Also, decimase is quite brunescent.
Yes.
I was gonna
Deep,
say that,
deep to the sequestrum.
whatever causes that pigmentation of the stroma itself, it's blading to that membrane too, which is kind of funny.
Yeah.
All right.
Wow.
All right. Yep. And then our little pink strand of material that was in the rupture here is a free edge decimase membrane that's naked, doesn't have anything on it. And then again, lots of neutrophils, fibrin, and stuff on plugging or trying to plug the hole. And then a little bit of more evidence of collagenylysis on this side. The inflammation extends a little bit into the anterior chamber and into the iris.
Is there some blepharon?
I don't remember noting some blepharon. I don't think that there was.
Or there's a fold exactly where we want to look at it.
Right. So, like I said, it was a little bit hard to sort of get a nice section. Even the lens didn't quite hold in there. We didn't quite get the optic nerve head and optic nerve, but the posterior segment of the globe was fairly unremarkable. And then the other thing I wanted to point out over here on this iris are these little cysts along the posterior iris, some iridociliary cysts, which they also noted was present in the right eye as well. So we often associate these with trauma in cats, but they can also be present and masquerade as masses. So that is something to potentially keep on your differential list for potential masses in the eyes associated with the iris. Yes. So it's a nice corneal sequestrum and just a lot of corneal disease, ulcerative, collagen-lytic, and a paraxial perforation with iris prolapse there. Some inflammation sort of extending into the eye a little bit, some endophthalmitis in the anterior chamber there, some hyphema or hypopyon stuff. So don't really know the exact cause of corneal disease, but the collagen-lysis probably didn't help either as well. So that was just kind of a fun one. And looks like we're at time. So if we're good, thank you all for joining us, and we'll see you guys in 2 weeks.
Thank you. Could we just hear what Sesame's membrane maybe sounded like?
Oh, yeah.
One more time.
Yeah.
I love that so much.
Yeah, we should have turned on the camera for that.
I know.
Thank you.
Yeah.
All right, stop recording. Good.